Okay, well, good afternoon, everybody. And it's a real pleasure to host for this BTRU seminar series, Professor Henrik Ullum. So Professor Ullum is a professor of clinical immunology at the Institute of Clinical Medicine at the University of Copenhagen, and he has recently taken a directorship role for this research institute, the Statens Serum Institut in Denmark. And we've been working together with Henrik for many years, since the inception of our BTRU, or actually even before. It's a real pleasure to have Henrik back on this floor, this time virtual one. I hope we'll be able to host you as well in a real one in the near future, and really looking forward to your talk. So Henrik, up to you.
Yes, thank you, and thank you for the kind invitation. And truly, it's been a long collaboration as we have been going through a similar journey on establishing large-scale blood donor studies and large-scale biobanks. And as Emanuele mentioned, I recently changed this direction since I'm now become the CEO of the Statens Serum Institut. So I'll just introduce that if I can change my slide here. This looks a little strange to me. Right, sorry. Can you see my
Nope. Oh, no.
One second, please.
So while Henrik is trying to fix this problem, I think just to remind ourselves, please be muted, and then at the end will be time for question. If you raise your hand, I'll call you on for the question.
Can you see my screen now?
We can see your screen, but we can see your Zoom page. So I think it's not your slide.
Now you can see something
Yes.
looks like a slide. Thanks.
Yeah.
Sorry.
Perfect. No worries.
Yeah. Okay, I put the wrong version of the slideshow on before, sorry. Yeah, so just as mentioned, I just took over the CEO role of the Statens Serum Institut, which is like the equivalent of Robert Koch Institute, or a mini version of the CDC in the USA. So our main duty is to ensure preparedness against infectious diseases and biological threats, as well as control of congenital disorders. Normally, here works 1,000 individuals, but at the moment during this COVID epidemic, I think the number is more like 1,300 approximately. And it's an old institution, 120 years of history, and of course with a long list of duties in the public health support. But as mentioned, especially focusing on infectious diseases, congenital diseases, and also we house the National Biobank and related health registers, which are important for the present talk and for our mission. So just to take a look at what we're doing in regards to COVID-19 surveillance. If you take a look at this slide here, you will see at the upper left triangle corner, you'll see some of the things that we collect. So every day we perform here in this institution 150,000 PCR diagnostic tests of COVID-19. And then we run the microbiology database for all microbiology in Denmark. And as such, we collect the something around in total 200,000 PCR tests per day and a almost similar number of antigen tests. And that's actually means that something around a third of the population is being tested every week, which is like quite massive compared to the rest of the world. In Denmark, we decided very early that we needed to have a focus on new variants of the virus, so we sequence all the isolates, and therefore we keep a good eye on mutations and have been able to follow the growth of B117 and also to follow the lack of growth of other variants of concerns. Then we also house the vaccination register, which of course is important in the present rollout of vaccination, but also important to follow the effect of vaccination. And as you all are working in epidemiology, you know that the goal is when you have access to other data, and you may also be aware that in all of Scandinavia, we have these central person registration number that we can link all individuals completely together. So we link these data associated with COVID-19 with the National Patient Register, the civil registration system. We have social data on occupation and workplace, and even data from nursing homes, by which we can, in quite detailed way, monitor the epidemic. And that's interesting because, I mean, I come from a world like yours, with primarily focusing on research, but now all these data are not only used for research, they're actually used in day-to-day managing of the epidemic. So what we do, we follow trends, we assess severity, we identify particular risk groups, we describe transmission chains, detect new virus variants, estimate vaccine effectiveness, side effects of vaccinations, and assess effect of different interventions. And of course, this is not easy because we're not talking about randomized controlled trials. We are talking about monitoring abundance of things that we do as we go along in the epidemic. And therefore, it's not always easy to describe the effect of each intervention that we perform. As mentioned just earlier, we do sequencing of all our samples. We have for the diagnostic samples, for the PCR samples, we have two lines of systems. One for people that are not particularly sick, and that's the line of PCR tests that we have here in Statens Serum Institut, Test Center Denmark, TCD. And then we have the clinical microbiology departments that do all the patient diagnostic. All the positive samples, they feed then into sequencing, and with that we can then follow the particular variants. And of course, we try to share that in international databases, so these can also be learned from international perspective. And of course, what we look forward to is also link those with human genetics, so we can at the later stage start to learn about what is the interaction between the human genetics and the viral genetics. As another example of how the toolbox of epidemiology suddenly can come into play, not only in theory but in actual handling, is that a lot of our intervention are actually based on mathematical modeling of the epidemic. So we have a population SIRE model, and we also have agent-based models, like two different models. One one is kind of considering population and having as a assuming homogeneity, which of course not is true, but it's a simpler statistical model. Whereas the agent-based models, they consider individuals and are therefore more advanced, but also more heavy calculations, and therefore it's not all our calculations we can handle in these agent-based models. And the whole idea is that we, for instance, right now, as I just mentioned to Emanuele, we are opening the Danish society. We are in the middle of a big opening of the Danish society, and all our interventions are based on modeling where we try to predict, okay, what do we think will happen with the epidemic in the near future and in the more distant future? How do we see the number of daily cases, and how do we see the number of future admissions to hospitals, so we don't get an overstretched hospital system? And of course, to do this kind of mathematical model, we need input variables. I think everyone working epidemiology knows that. These are the things that we put in. For instance, the more infectiousness of B117 we put in. We also, from UK data, initially learned that also B117 is more severe. We put in the vaccine rollout, the population prevalence, seasonal effects, and then all these, we have very large testing system, how that works. But to link back to the blood donor data, we also need data on immunity, as immune individuals are not susceptible to the infection. So therefore we need to keep track on immunity. And for that, I use my previous collaboration with blood bank colleagues, and we put up a system where we actually screen all blood donors for antibodies to SARS-CoV-19, and by that we can simply follow the prevalence of antibodies, and you can see that in week 14 the prevalence was somewhere around 8%, and it actually hasn't grown that much. These are excluding individuals that state that they have been vaccinated. So when we do predictions, we take those out of the risk population. And actually interesting for anyone interested in antibody surveillance, we can actually see that although we still have new cases, the antibody levels in the non-vaccinated population are not increasing anymore. And that means that although we have new cases that must develop antibodies, some will have antibody responses that are so weak that actually in the tail of the population, there will be some individuals losing their antibody levels, and we are yet to learn what does that mean for their susceptibility to infection, but we intend to study that down the road. Coming back to the blood donors, actually when we started this intervention, we did it with a different purpose. That was back in 1 year ago, and at that time we really didn't know how many were infected by this infection, and therefore we did know the mortality, but we didn't know the true number of infections, the what we call the dark figure in Denmark, and we came with one of the first suggestions of an infection fatality rate in this range, but importantly only in young healthy individuals, so 9 per 10,000 infections among in a blood donor population. And secondly, which is even more important, we also took previous blood donors, called them in, asked them to provide blood samples for antibody detection, and that we came with an infection fatality rate that was 65 times higher in those individuals that had retired. Which is important, and also another important, but which has also been stated by many others, is that a lot of the individuals did not really report previous symptoms of diseases. One of the other things that we are housing here at Statens Serum Institut is the Euromoma program. The Euromoma program was initiated many years ago and actually is monitoring mortality across Europe. You can see the countries participating at this figure, and was actually mainly set up to monitor excess mortality by influenza epidemics. So every year you can see these peaks of mortality in the winter season, peaking in January, February, and then waning off in March. And looking at the last 2 years, you can actually then have a larger view of, okay, how much excess mortality did we have in Europe through COVID-19? And for 2020, you can see this peculiar peak here occurring later than you would have in a usual flu epidemic. And then the last large excess mortality here, which was the big second wave that occurred more or less all over Europe. And just to focus a little on the efforts that may interest us in the room here, of course, I'm particularly interested in how we are doing in Denmark, and you may be interested in how it has been doing in the UK. And you can see basically in Denmark, we have been avoiding too much excess mortality. There was a little in this occurring in late December and January, but we also have a second peak, and that when we observe this increase in mortality and also the earlier increase in daily new cases and increasing incidence, we had a complete close down of society, which we luckily implemented quite early, and therefore we avoided a large peak in mortality. You can see in UK it seems like you have had higher excess mortality, but although the latest data are quite there's a more unsecurity about those late data because they may be changed, but you can actually see you are in an under mortality state if these data holds true, which I think may indicate that you are on a very good path, probably through your very successful rollout of vaccines. So just to stay on the what has been successful in the Danish control of COVID-19. I think we have had a very strong political dedication for our government. They have been willing to make early close downs last spring, this winter. They've been good at allocating sufficient resources to all us working with it, and also communication from the start, being very clear in communication and saying, okay, we don't want this epidemic to tear our healthcare system apart. Something that has made it easy in Denmark is in the Danish population, there's a good deal of public trust. I think that has to do with the welfare society, the Scandinavian welfare society. And therefore, there's been a great willingness to accept restrictions in the population. I think that has to do with this social responsibility that people, even not at risk, are willing to suffer to save others. And also, we have been lucky to have good trust in the expert opinion. Of course, you have a minority that strongly disagree with what we are saying, but in general, there's a big trust in the population. On the more technical side, I think the digital preparedness has been important. We have all these registers, as I mentioned before, and that had meant that we can, from the very start, we have been able to provide a very detailed individual monitoring of the epidemic, and we have been able, through dashboards, but also through specific reports, to all authorities, share those data and allow them both at the highest level on the government level, but on very local level, to take correct decisions regarding the epidemic. And then also the digital preparedness has been allowing us to make a very effective vaccine rollout. As you may have heard, we put the AstraZeneca vaccine on hold, which kind of put us a little behind in the vaccine rollout, but in the early phase, we were actually leading in the EU area for rolling, for effectively vaccinating the population. Sorry for these. I just made these slides here. We've also mentioned the very high testing capacity. So when we compare us to the rest of Europe, we can see, okay, how can it be that we although we have already started opening the society, how come that we still have very low incidence and a very low mortality? We're the third lowest on both in Europe. And I think the very high testing capacity and then some very robust reactions to local epidemic flares has been the key to that successful handling of the epidemic. Then moving a little back to the blood donor data and the Danish blood donor study and the Biobank. I think all this work we have been doing and which I've been doing together with you guys for years also have to do with the paradigm of developing personalized medicine, where of course we all go through life born with a particular genetic profile. We have different diseases throughout our life, and then at a certain time point we get new diseases, and the final rollout of the final result of those diseases can be different. It can be everything from death to complete restoration of health. And of course what we would like to do is of course to predict this course on the individual basis. And of course, we would also like to do that on COVID-19 to be better to predict who would fall sick. And I think everyone working in this field agrees that to do that, we need as much information as we can get. That includes clinical information, it includes social information, but it also includes information that we can get from biobank samples and from various other diagnostic procedures, including different imaging techniques. And that's of course the whole basis why I for years and you also for years have been working on collecting biobank samples. That is of course because we think those samples are important in this predicting system. So in my new position, I'm lucky to, at Statens Serum Institut, we also host the National Biobank of Denmark. And as such, we host the Danish Biobank Register. And in the Danish Biobank Register, we have some of the largest biobanks in Denmark. And as such, I'm lucky because the two biobanks that I started in my previous work, the Danish blood donor study and the Copenhagen Hospital Biobank, they are now in this register. And for you working from the UK, it's important to know that this Danish Biobank register is open, so you can actually search in the Biobank register, and then you cannot see individual samples, but you can see how many samples there are with different phenotypes. So that information is digged out of the Danish registers, and then you can approach any of these biobanks and say, okay, we're working on this area, and we can see you have some samples that we maybe could collaborate on studying. The National Biobank has a total of more than 12 million biological samples in store, and have, of course, state-of-the-art robotic freezers and also state-of-the-art digital systems. And of course, we use that for different projects. But just to mention some of the COVID-19 associated projects, you can see we have access to diagnostic samples. These include throat swabs, more than 1 million of those, blood samples, and then of course DNA, plasma, serum, and we run a large number of studies on this. And a little later I'll also mention this large-scale host pathogen genetic interaction, which also includes blood donor data and Copenhagen Hospital Biobank data. So I'll focus a little on these two biobanks, which I worked with in my previous position. So the Danish blood donor study, I think I'll just take this one. The Danish blood donor study we initiated in 2010. We have more than 130,000 unique participants, more than 500,000 risk years, more than 800,000 plasma samples. We have genotyped the individuals in collaboration with Decode Genetics. And we have informed all our participants about this genetic studies by secure private emails. And here you can see the inclusion curve. So you can see it's been more or less a steady gradual increase in number of participants. For the data, we have data in 3 different questionnaires and 3 different generations of questionnaires in different, focusing on different subjects. And then we pair that with all these registered data that we have in Denmark, and in particular, of course, any healthcare contact is then kept information in the registers, and we can access that and mix that with all our data in the research project. Another added benefit is that we keep blood samples from all these participants at each time they come and donate. And that is important because that allows us to make case control studies. And in the present time where we are actually worried about this side effect of the AstraZeneca vaccination, we will go back to the blood donor population, because there's a lot of blood donors that are healthcare workers as well. So a lot of them have been vaccinated, and we will then go back to the blood samples and see, are there any systematic differences in biomarkers, and in particular some of these antibodies that has been associated with these important side effects, and see if we can see a development in those antibodies that are broader than the clinical manifestations, or more frequent than the clinical manifestations that have led to the worry about the AstraZeneca vaccine. Then to mention another large biobank is the Copenhagen Hospital Biobank. We keep routine samples and done that since 2019, have around 500,000 samples and very, very high numbers of different diseases. And these are collected from all of the greater Copenhagen area. And in that biobank, we have a number of projects, and you can see them lined up here. And importantly, we of course also very recently developed a COVID-19 protocol. And in that COVID-19 protocol, we will couple the data from the blood donors, so the blood donors that have been infected by SARS-CoV-2. We will take all the individuals that are in the Copenhagen Hospital Biobank that are genotyped and have a diagnosis, and then we will genotype the individuals that have been tested positive on, and we have samples in the National Biobank. And with those, we will then combine all the register data and describe human genetic variation into and the importance into clinical development. And of course, we will join these international efforts because I think a lot of meta-analysis is being done. I know a lot of meta-analysis is being done, and our data will feed into those data. So at the end, importantly, it's important to realize blood donor data and biobank data. They are important. They are important not only for blood donors, they are important on a broader scale to learn about health and disease. And of course, it's also important in a medical crisis such as a pandemic. And from my present position, I can see that, and I enjoy that, to use some of these earlier data sources I worked with. So that is basically what I had to say. Thank you.
Excellent, and thanks, Henrik. I think very fascinating overview about what you've been doing, and actually what are the potential for the different data and different sorts of information that you put together in the Statens Serum Institut. I'm sure that Henrik would be happy to address questions. So while you're preparing your question, I'll start. You show some of the interesting data about the seroprevalence in blood donors. How much do you think that they reflect actually the general population in Denmark, and in some of, given that we know that the donors tend to be in some way healthier or more health aware compared to the general population, and how much do you know in Denmark that's been the seroprevalence has been reflecting actually that in the general population?
I can answer that because there has been two parallel initiatives, and I've been involved in both. So here from Statens Serum Institut, there were like random collection of individuals that have been invited in for bleeding and antibody testing, and the correlation between the levels in the blood donors and in the general population have been pretty good. And also there's a second thing you need to learn and accept. That is, although we know there's a lot of selection bias in blood donor population, the healthy donor bias, actually there's a very, very strong bias into such an invitation to such a random sample. And I think this is pretty much what you also faced when you established the UK Biobank, because I mean, I think in Denmark, we made this random sampling, and then we set up like 5 or 6 collection sites. At the end of the day, I think it was around 10% that responded to the invitation, and how that selection actually works and who is it that comes and provide that information when in such a random sample, we don't really exactly know. And I think something about being close to the collection site, something about being willing to provide information to others is important. And I think that's a lot of the same selection criteria you have into the blood donor population. So I'm afraid that there's, unless you really go out and knock every individual's door and say, okay, we're right here, you just need to put your arm forward and then we'll very easily take a blood sample from you, I think we'll face a lot of the same biases. I guess, which we also suggested, but it was never implemented. I guess if one had supplemented this with, for instance, a routine collection of leftover samples from the hospital system, I think that would have given a different view of the situation. Maybe not different figures, but at least a more robust figure, because then the selection criteria would be broader.
Excellent. Thanks. Any question from the audience?
I actually have a question about, so it's been a really great talk. Thank you so much for this. I have a question about the variants of concern and the variants under investigation. Are there plans to assess their effect on transmission, disease, and potentially vaccine escape?
Yes.
In addition to, I think you mentioned B117.
Yeah, there's a lot of plans, but sometimes, unfortunately, lack of resources. Because I mean, as you can imagine, a lot of my staff is really deeply involved in just day-to-day business, making sure that we can provide these data, that we can. So some of the important critical questions, we don't always have time or resources to really answer all those questions. And on top of that, we have, we wanted to share these data, because there are Danish researchers and international researchers who would very much be able to help us on this and collaborate on this. But we have been challenged legally by GDPR challenges. Say, okay, a virus sequence can be unique, and therefore it's not truly anonymized, and therefore we have been challenged if we can even share it, which is it's a disaster for collaboration in the microbiology field, because sharing, we're not talking about sharing human genetic information. We're talking about sharing genetic information on microbiology strains, which is not really sensitive. It may be unique, but it's not sensitive. But this has nevertheless been challenged. So we are fighting to be able to share that. And once we can do that, we also have good collaborators that will dig deeper into this, because I think it's important. I think it's important to, and I think I'm quite convinced that we will see a surge of new infections once we have immunity, whether that is vaccine induced or infection induced by new variants. I think what we are seeing with these new variants occurring in different countries and continents, these are actually second wave selected variants, and they, depending on what vaccine you use and the strength of the immune response, I think we will see some degree of second wave variants of concern epidemic now, and therefore we need to track that down. And of course, since we are sequencing all our positive samples, and since we are able to link it, it's a disaster. We cannot really answer this question.
Thank you.
Thanks.
Any additional question from the audience? Well, I'll maybe follow on about this sharing data and allow to collaboration. You mentioned about the hospital biobank. That's, of course, it's a great resource that you've been able to develop together as well with the blood donors biobank. And you know, what is the mechanism of collaborative work or open or accessing to data that the institute is applying or is envisaging in the near future?
Well, I'm not sure I got the question completely, but the thing is, for these two resources, which I have been like, especially the Copenhagen Hospital Biobank, was kind of, I think I invented that one. With my change of position, I needed to give the leadership of those biobanks over to a good colleague, Professor Sisa Ostrovsky. So she's taking care of that, and I think the way of collaborating is a bit different than for instance, the UK Biobank. So it's not that you just put in a application and then you can get data. So I think it's pretty much like how you collaborate in the interval study. It's on a case-to-case basis and based on good collaborative a sharing of ideas and concrete ideas together. But I mean, the idea I tried to put into it is that we should be as collaborative as possible, internationally and nationally.
Actually, that was actually addressing exactly my question. Thanks. Good. Any other question from the audience?
Thanks, Henrik. I've just been looking at the website and it's got a lot of information. You mentioned questionnaires. Are these sort of periodic questionnaires, or they're sort of done on a study-by-study basis?
In the Danish blood donor study, these are questionnaires that they were first developed on paper, then we transfer them electronically, and then that's 3 different types of questionnaires. Did that answer? Maybe I need to have it repeated.
No, I was just wondering about using the questionnaires on a longitudinal basis, particularly in relation to the.
Yeah. Okay. Now I get it. So what we have had parts of the questionnaires we have used in different versions of the, for instance, smoking habits, exercise habits. The short form 12 questionnaire has been repeated in all versions of the questionnaires, and as such there is a potential of having at the moment 3 repeated responses of all these questionnaires. We haven't implemented like every time you come and donate basic questionnaire, which would be a pretty good idea if you could digitalize it and kind of make it very efficient, so the donors could simply, while laying on the bed, could fill it in. But again, that's now out of my hands. That will be my my previous colleagues who would need to take that that next step.
Okay, thank you.
Excellent.
So,
Well,
yeah, so basically what, I mean, this has been a really sharp cut, or I mean, I had needed to kind of say, okay, this is a new professional life. So although I, in a very good contact with my previous colleagues, I don't have any say over what is happening in these two biobanks at all anymore, which is fine because I have plenty to do.
Well, I'm sure, and actually, this Serum Statens Institute seems an excellent place where to build even bigger endeavor and bigger collaboration that can serve as well the public health and in the immediate crisis of COVID-19. So it's really excellent what you're doing. So, well, if there's no other question, thanks again, Henrik. I think it's been a pleasure, even if
Likewise.
to have you here, and I hope to be able to invite you soon on a face-to-face meeting and only on this virtual meeting.
We'll look forward to it. Take care.
Thanks
Stay
a lot.
safe.
Thanks.
Bye.